All right, so I'm recording. My name is Lexi Graham, and this is for Respiratory 2480. And in this four-part video series, we're going to be talking about the gold standards for COPD exacerbation. This is video one, and we're going to be talking about identifying COPD and what that looks like. So COPD, also known as chronic obstructive pulmonary disease, it is described as a heterogeneous lung condition characterized by chronic respiratory symptoms such as dyspnea, cough, sputum production, and/or exacerbations due to abnormalities of the airways, like bronchitis or bronchiolitis, and/or alveoli, which would be emphysema, that can cause persistent and often progressive airflow obstructions. People with COPD also frequently have other comorbid diseases that also influence their condition and prognosis. These other conditions can mimic or aggravate an acute exacerbation. So known causes and risk factors. So these can be caused by genetics or environmental factors. For the genetic side, the most relevant, and it is also rare, genetic risk factor for COPD identified to date are the mutations in the SERPIN-A1 gene that leads to an A1 or alpha-1 antitrypsin deficiency. A number of other genetic variants have also been associated with reduced lung function and risk of COPD, but their individual effect size is small. So this alpha-1 antitrypsin deficiency is basically something that you have present at birth, and it is genetic. So basically genetic COPD. And then environmental factors that can cause this would be mainly tobacco smoking, inhalation of toxic particles and gases from household and occupational exposures, outdoor air pollution, and then biomass exposure. Diagnosis. So who to consider? So a diagnosis of COPD should be considered in any patient who has dyspnea, chronic cough, or sputum production, and a history of recurrent lower respiratory tract infections, and/or a history of exposure to risk factors for the disease. So, but if their spirometry is showing the presence of a post-bronchodilator FEV1, FVC less than 0.7, this is mandatory to establish the diagnosis of COPD. So if you want that FEV1 percent is less than 0.7, that is the best way to establish the diagnosis of COPD. The main goals of the initial COPD assessment are to determine the severity of airflow obstruction, the impact of disease on the patient's health status, and the risk of future events such as exacerbations, hospital admissions, or even the possibility of death. These are all used to guide the treatment of the COPD, of the disease. And then here I have a few pictures just of a few symptoms that you might see in someone who has COPD that will help and aid in their diagnosis: the chronic cough, dyspnea, excessive sputum production. So other possible symptoms would be chest tightness, fatigue, possible weight loss, muscle mass loss, anorexia, or wheezing. And then, so after that, we have tests and assessments that aid in the diagnosis of COPD. So we have spirometry, we have a pre and post bronchodilator testing, the modified MRC dyspnea scale, and the CAT assessment. We're going to go through each of one of these in detail. So spirometry. Spirometry is a medical test that measures lung function. It can assess how much air a person can breathe in and out, as well as how quickly they can exhale. So forced spirometry is the most reproducible and objective measurement of airflow. It is a non-invasive, reproducible, cheap, and readily available test. So this will assess the severity of the lung disease, evaluate the effectiveness of treatments, and monitor changes in the lung function. So, so the FEV1, this is the airflow limitation of severity in COPD. Mild would be greater than or equal to 80% of the FEV1 predicted. The second worst or moderate is 50 to 80%. And then severe is 30 to 50%, and very severe is less than 30% of FEV1 predicted. Spirometry continued. So this is kind of what it looks like if you are going into the body box. This last one right here that you saw was more of a handheld one that you can take to the room for the patients. So the first step in performing a spirometry test is having the patient perform a forced vital capacity FVC maneuver, which is the volume that can be expired as forcibly as rapidly as possible after maximum inhale. The FVC maneuver measures FEV1, FEV 200 to 1200, FEF 2575, and peak expiratory flow rate. FVC and FEV1 together help determine the FEV1% or the FVC over FEV1 ratio, which is FEV1%, which is the best indicator of COPD. So FEV1, the amount of gas expired in the first second of the FVC maneuver. When the FEV1% is less than 70, this would indicate an obstructive airway disease. So the main point here, less than 70% indicates you have COPD. A pre and post bronchodilator test. So while post bronchodilator spirometry is required for the diagnosis and assessment of COPD, assessing the degree of reversibility and of airflow obstruction to inform therapeutic decision is no longer recommended. So the degree of reversibility in a single patient varies over time, and if the obstruction pattern is reversible, the post-bronchodilator test should increase by 12% or 200 milliliters or by 200 milliliters or greater. And then in line with other national and international guidelines, GOLD has recommended using post-bronchodilator values when considering a diagnosis of COPD. Historically, post-bronchodilator values were considered more appropriate for confirming a diagnosis of fixed airflow obstructions, as they were thought to be more reproducible. To be useful in excluding asthma, and could identify volume responders to bronchodilators in whom the obstruction was revealed by bronchodilator-induced increased FVC. However, it is now recognized that the bronchodilator response has little value in differentiating asthma from COPD. That pre-bronchodilator values are reproducible in obstruction only found on post-bronchodilator measurements is uncommon. Pre-bronchodilator spirometry can be used as an initial test to investigate whether symptomatic patients have airflow obstruction. If the pre-bronchodilator spirometry does not show obstruction, performing post-bronchodilator spirometry is not necessary unless there is a high clinical suspicion of COPD, in which case an FVC volume response. Next, we have the MRC dyspnea scale. It's basically a dyspnea questionnaire. So the MMRC, Modified Medical Research Council, dyspnea scale was the first questionnaire developed to measure breathlessness, which is a key symptom in many patients with COPD, although often unrecognized. So you have grade 0, 1 to 4, and it just asks you basically how severe your breathlessness is or your dyspnea is. So grade 0 would be I only get breathlessness when doing with strenuous exercise. Grade 1 is I get short of breath when hurrying on the level or walking up a slight hill. Grade 2 would be I walk slower than people of the same age on the same level because of breathlessness, or I have to stop for a breath when walking on my own pace on the level. Grade 3, I stop for a breath after walking 100 meters or after a few minutes. And then grade 4 would be I am too breathless to leave the house, or I'm breathless when undressing or dressing. So these are just basically levels up in how breathless you can be, and you check it, and this helps aid in your diagnosis. You also have the CAT assessment. So this is an 8-item questionnaire that assesses health status in patients with COPD. It was developed to be applicable worldwide, and validate translations. And validated translations are available in a wide range of languages. So this can be used universally. The score ranges from 0 to 40. The cut point for the CAT assessment is 10. A higher score indicates a significant impact of COPD symptoms on a patient's daily life, meaning a score above 10 would suggest a higher level of symptom severity in a COPD patient. And this is just kind of what it looks like. Again, this is out of 0, ranges from 0 to 40. So some other helpful factors that may aid in the diagnosis of COPD. So you have diffusion capacity testing, chest x-rays, CT scans, and exercise tests. And these can all help